This is the To Health With That Naturally Healthy in No Time podcast for big health topics taken in small bites. I'm your host, naturopathic Dr. Amy Newsel, and this is Season 1, all about the MTHFR mutation. This week, let's talk about homocysteine, MTHFR, and COVID-19. At least about what we know right now. Of course, in a pandemic, we all want to know how it might affect us specifically. That research takes a lot of time and a lot of money, and it usually comes after the big stuff, like how does this spread and why does it kill people? In good-ish news, COVID-19 has now officially been around long enough for some of the smaller, more specific areas of research to be done. This includes the very first steps on research into the interplay between homocysteine, MTHFR, and COVID-19. This particular study came about because there have been big differences in COVID disease severity between different geographic areas as well as between the genders. The study I'm talking about was published in November 2020 in a journal called Medical Hypotheses, which is not peer-reviewed research, but includes important theoretical papers. So I do want to emphasize that this information is theoretical, but based on sound principle. Here is a summary from the article entitled Life-Threatening Course in Coronavirus Disease 2019, parentheses, COVID-19. Is there a link to methylene tetrahydrofolate reductase, parentheses, MTHFR, polymorphism, and hyperhomocysteinemia, which is a nice brief title. At the date of publication of this research, COVID-19 was associated with an 8.8 mortality rate in those above 60 years of age, and 0.46% for patients aged below 60 years old. Countries with the highest mortality rates at that point were Italy, Spain, France, Iran, and the USA. A recent report from Italy showed that the vast majority of those infected who were critically ill were older men, 68% of whom had at least one comorbidity. The worldwide mortality rate is higher among men almost by a factor of 2, so the mortality rate for males to females is 1.7 to 1. In Italy, high rates of ICU admission, ICU mortality, and overall mortality have been seen, and the deaths from COVID-19 are often associated with high neutrophils, which is one of your white blood cells, high levels of pro-inflammatory cytokines, abnormal coagulation tests, and disseminated intravascular coagulation. The most common comorbidities were hypertension, cardiovascular disease, hypercholesterolemia, and diabetes. The article goes on to summarize the high points of MTHFR. The MTHFR enzyme is the most important in the methionine pathway. It regulates fundamental processes such as DNA repair, neurotransmitter function, and membrane transport. The C677T mutation has been suggested to be protective against certain cancers, including colon and acute lymphatic leukemia. The mutation leads to a thermolabile variant of the MTHFR enzyme, in which the dissociation rate of the cofactor flavin adenine dinucleotide, FAD, this is actually B2, it's the active form of B2, is increased, thus reducing the activity of the MTHFR enzyme by 50% or more. Now this is interesting, and I've never seen this before. So what they're saying is that the MTHFR enzyme, which is produced by the C677T mutation, is less efficient because it doesn't bind to the cofactor as strongly, right? That binding gets loosened, and the cofactor here is vitamin B2. In people with a medium skin tone, the function of the MTHFR enzyme is largely preserved as long as they have sufficient dietary folate intake. Now, I'm not sure what medium skin tone has to do with that, but we will be looking into it. Don't worry. With insufficient folate intake, the production of 5-LMTHF is reduced, which leads to the accumulation of key metabolites, homocysteine included, to toxic levels. MTHFR is the most common genetic cause of hyperhomocysteinemia, Low folate status resulted in significantly higher levels of homocysteine in men specifically. Research suggested that the C677T mutation is associated with significantly increased risk of coronary artery disease only in homozygous men. There are other things that are a risk factor for developing high homocysteine outside of the MTHFR gene. One is chronic kidney failure, hypothyroidism, cancers of the breast, ovary, and pancreas, smoking, don't do that, alcohol consumption, physical inactivity, advanced age, and male gender, so men are more likely to get high homocysteine than women. In addition to the risks of high homocysteine that we've talked about before in other posts, an acute high homocysteine situation can be triggered independent of folate status when a systematic inflammatory process is triggered, like, for instance, by a virus. Like, for instance, coronavirus. This process boosts inflammation and releases a tremendous amount of reactive oxygen species. Those are the free radicals, which can overwhelm your antioxidant defense systems. This is potentially an even greater issue in MTHFR folks because we have the potential for lower glutathione than average, and glutathione, as you know already, is the master antioxidant. This whole ugly cascade activates something called nuclear transcription factor, or NF-kappa B, which accelerates viral replication in SARS-CoV. So what this is saying is, for MTHFR folks, because of our lower glutathione, we might have a greater risk of this acute high homocysteine scenario that causes SARS to replicate more quickly. The study also cites one case report, which is not very much research, but at least it's a start, in which glutathione supplementation led to a rapid symptom improvement in 2 different cases of COVID-19. Interestingly, COVID-19 patients' plasma homocysteine levels show predictive value for the progression of pathological findings on chest CT. So that means the higher the patient's homocysteine is, the more likely they are to show damaging changes in their lung tissue on a chest CT scan. Also, these changes began to show at a far lower homocysteine level than the one that's usually used as a medical reference. So medically, we tend to use 15 micromoles per liter, and that is normally recognized as a high value, but in COVID, negative changes began to show at 10.58 micromoles per liter, which suggests that perhaps our guidelines should be changed. So what do we do about high homocysteine, MTHFR, and COVID-19? This study actually makes some suggestions. Patients at high risk with COVID-19, such as the elderly with comorbidities, should also be screened for high homocysteine. Sounds simple enough. Those with 8 micromole per liter or higher homocysteine should implement a folate-rich whole foods diet, fruits, vegetables, whole grains, good protein sources. Hopefully, everybody listening is already doing that. These individuals should also add 5-MTHF supplementation. Folic acid should be avoided by these individuals, as supplementation can have the opposite of the desired effect, especially in individuals with the MTHFR polymorphism. We all know all about this already, but I'm going to read it anyway. This is thought to be because unmetabolized folic acid accumulates, which inhibits MTHFR, and also folic acid competes at binding sites with 5-MTHF. Okay, B6, B12, and B2 should be added as well, as they are cofactors for the MTHFR enzyme or in the methionine pathway. Supplements with demonstrated antiviral properties can be added, including vitamins A, C, D, E, selenium, zinc, iron, and omega-3 fatty acids. Strong antioxidants, including vitamin C and glutathione, have shown positive results for COVID-19 outcome. At the end of the day, it looks like taking care of yourself appropriately for MTHFR and following the positive steps to balance your methylation that we've been talking about is actually the best defense for those of us with MTHFR against the worst of the outcomes for COVID-19. Taking positive steps to manage your MTHFR doesn't mean that you won't get COVID, but hopefully it will reduce your risk of dying from COVID. Keep in mind that this study represents a well-researched theory, and it has yet to be proven in clinical trials. But this is where the data stands today. Thank you so much for listening, and thank you so much for being here. We'll talk more about homocysteine next week, because it is actually a big topic for MTHFR and one of the biggest risk factors. Also, I do hope you'll join me in the MTHFR community at community.tohealthwiththat, TOHEALTHWITHTHAT.com.